Now, let's talk about kazi. Hapa ni kazi tu ama Z. The Kenyatta National Hospital, we know, and we had a news in our news fixes yesterday, that the Kenya National Union of Nurses and Midwives had actually staged a strike at KNH, and they had several issues that they were raising. We now know that they signed a return to work formula between the management of the hospital and the union officials yesterday. So the nurses should be back to work today. Or are they? We want to hear from the acting CEO of the facility, Dr. Richard Lesiyampe, who's our guest. Good morning, Daktari.
Yeah, morning, Eric.
Karibu sana.
Yes. Asante sana. It's great pleasure for me to be on this very, very powerful, a very great station, not only communicating to our Kenyans, but actually the globe. And I'm also happy to meet Marian again, and I think Janet. Yes. The last time we were together was when I was the CEO, Jaramogi Oginga Odinga Teaching and Referral Hospital.
Yes.
I want to confirm that all nurses of Kenyatta National Hospital have resumed duty today at 7:30 a.m. following our return to work formula yesterday. Yes.
Very good news. As we get into that conversation, we want to start by welcoming you with a quote. Some words that were said by somebody, and let's see your reflection of those words today.
This one was said by Dambudzo Marechera, who was a poet and writer from Zimbabwe. He said, "Disorder is the highest stage of order."
Powerful. I think what I can say is that when you talk about disorder, we're also saying that there are people also who take advantage and actually who excel when there is disorder. But similarly, we can say that disorder comes first, then you create order. So I think...
That's literally what he meant.
Yeah.
But he said even that order is manufactured. The disorder, it's still disorder, but it's manufactured as order.
Yeah.
So, yeah.
So it's all disorder.
It's all
Essentially.
Okay.
Let's maybe start with setting the scene. And it's good to know that the nurses are back to work as of this morning. What led to the strike? Or the call for the strike?
Yeah, thank you very much. That's a very, very pertinent question. What I would like to say is that this strike took place because of so many reasons. One, majority of the issues were historical. And sometimes it's very unfortunate when we sign paper and agree, that we resume work and we're going to execute and implement the following, and then we fail. Some of the issues go back up to 2017, where there was our return to work formula, where it was agreed that, the nurses go back to work. There was an industrial action, and there were issues about their nursing uniforms allowances. There was issue about health service allowances, and there were issues about review of annual leave allowances, and these were never done. So that's one of them. The other issue was basically that a number of them were employed, I think, for the last 6 years or so, and they are still on temporary terms. And, they felt that, they needed their colleagues to be on permanent and punishable terms. We also had, one or two other issues, particularly on the issues of workloads, that they felt that, sometimes they are overwhelmed, they are overworked, they go through burnouts and, these kind of things. So they had quite a number of reasons. I think, though it was mentioned 5, I think to me there were about 7 of them. And that's basically what I can say.
Let me ask, I know we're going to go into the return to work formula and really looking at the long-term fix, but it is a pattern that you come into something that is already messy. We've heard the same thing being said, for example, of people saying we've inherited the NHIF, debts, etc., and nights coming into SHA. So when you're coming in to a role like this, Mr. Lesiyampe, as acting CEO, how do you try and figure out what needs to be addressed first? Because I'm sure when you came in, you already knew that there were outstanding complaints. You already knew that perhaps nurses were frustrated. How do you reconcile what needs to be ironed out and vis-a-vis what can wait? Because it sounds like maybe they said, this one can't wait. That's why. So how did you try to figure out what needs to be ironed out first?
Yeah, thank you very much, Janet. The point here is that when I came in, I actually assessed, what are the challenges. I also got from them. And it happened that I have on record 44 challenges that are facing staff of Kenyatta National Hospital. Okay. And I also decided actually to work on a number of them, immediately. I didn't have to wait and say that this was historical or whatever. I think I had to run with what was very, very critical at the time. One, there was congestion at the accident and emergency, where it's a very, very important spot to save lives. And where accident and emergency, where now we have actually transformed it to call International Trauma Center. I had to work on it, because the core business of KNH is actually to save lives and to treat patients. And immediately I opened up more spaces with my management. There were 32 spaces, for oxygen, within that accident and emergency. We worked around it. We have now 72 spaces. We also decided actually to, separate patients, to have those on medical emergencies, separate from those who have trauma and those actually who can walk in. And these are actually tremendously improved the services there. And I think that to me was a major, major priority. The second item, and I think all of us appreciate, was the issues of having some equipment, very, very critical equipment. I was in KNH 12 years ago. I think 12, 13 years ago. And it happened that some of the equipments have grown old, actually, I can say they're actually old, they are not properly modernized. Of course, a number of new equipments have been brought on board. And therefore, I had to really work with my team to see to it that, we have equipment, because without equipments, without instruments, the employees will not actually perform. Similarly, we also had issues of leakages, I think financial leakages, certain places of waste, and that kind of thing. Okay. And therefore, I had also to streamline the organizational structure of the hospital. So these are some of the things that I gave priority. Notwithstanding the fact also on the issue of the nurses, I actually also engaged them. In fact, the first thing I did with them, I actually held a meeting with them. There are 2,000 of them, and I had a kamukunji with them. And the first priority they said is that, first of all, reorganize our structure. We need nurses to be put in positions through a transparent, competitive process. And we actually advertise those positions, and within 2 months, we already have, nurses in positions competitively. So the thing is that it's barely 6 months since I went there. And with 44 problems, my brother Eric, very well, it has to take some time. So I want to say that I have also other priorities. One of the other priorities is the issue of digitization. An hospital, Kenyatta National Hospital, is the second largest hospital in Africa. In fact, in bed capacity... The entire continent or just Sub-Saharan? Yes, in Africa. In Africa. I mean, in Africa. It's the second largest hospital in Africa in bed capacity, in terms of bed capacity. The first one is Chris Hani in South Africa, with 3,500. Where bed capacity is 2,300 now, going to 2,500. We can also boast of the best specialists. We are talking about consultants numbering not less than 500, including of the University of Nairobi. And we handle, the highest specialized cases, and even performing world-class, surgeries. We are no longer the apex of East Africa. We actually, in the leagues of Africa. And even in comparison to the nurses we are talking about, we have actually the best trained nurses globally. And I think that's why I have to come to that question, when you talk about workloads. Our nurses are the best globally. In fact, you go to Zimbabwe, you have been quoting somebody from Zimbabwe. Zimbabwe, Botswana, Namibia, I think England, Britain, Australia. Our nurses are all over there. Including even our doctors. In fact, Kenyatta National Hospital, the University of Nairobi, has trained about 15,000 doctors, in the past decades. And 5,000 of them are actually out of this country, doing wonderful job there. So what I can say is that we are indeed a premium hospital. We are actually the best. And we need to actually be a digitized hospital. Unfortunately, we are partially digitized. In some instances, our patients have to carry paper, There's delays, in terms of provisions of healthcare, in terms of efficiencies, and operational efficiency. And therefore, I had to actually work on that. And as we speak now, we're actually rolling today, fully automation of Kenyatta National Hospital. It has taken me 3-4 months and with my team, but today, 15th of April, we are rolling it out after 2 months of, working out that great system.
Okay. Yeah. Today is a
today 15.
That's really good news. And you're very efficient. Even when we talked to you when you were at Jaramogi Oginga Odinga Teaching and Referral, you could tell that there's momentum, things are being done, have been done, and we're moving towards this idea of quality, proper healthcare, right? And I think Kenyatta National Hospital is one of those places. But then the challenges that are usually there when it comes to human resource are quite heavy across the board for our public health sector. When you think of the 2,000, the number of nurses, 2,000 nurses that you have at Kenyatta National Hospital. You said they had their issues, including workloads, including the employment's, terms and everything like that. When you think of those, which were the most urgent? And then now we can go into the return to work formula. Which were the most urgent for you? Which were the most urgent for them?
Fine. The issue of converting those on temporary terms to permanent pension was urgent for me. And I can assure you that I have a very, very robust and very, very enterprising board of directors, led by our chairman, Abbas Guled, which most Kenyans know he was a great man with the Red Cross, and the other directors who were there. So what I did is that I presented these issues to the board. In fact, I presented a paper on converting this staff on temporary terms, not only the nurses, but I think all the staff I found on temporary terms who have been there for almost 6 years. There are actually 601 of them, and I presented to the board, and the board approved. And what they said is that, we have to do it in a structured manner, that we have to get a budget, we have to get approvals. And the decision was that we actually transit them to permanent pension, but effective 1st of July. I also have medical officers, about 193 of them who are also on temporary terms, I think on contract terms. We also had, we have also clinical officers, on the same. We also have a number of laboratory officers. We also have a number of, staff, in different departments. So the first step I did was actually to ensure that those nurses are transited to permanent and pensionable. Okay. The second item was on the medical cover, which they have actually had. It happened that they used to have a medical cover in the past, I think collapsed 2 years ago, and they've been having an in-house one. Similarly, it requires substantial resources. I also presented the same to the board, and the board approved, in fact, in March, and it was agreed that, we put in the budget, we also put in our procurement plan, and it's actually supposed to be effective 1st of July. The only thing is that...
This is a separate medical cover, not shift.
Yes, this one is an external medical cover, an insurance, medical cover, where you actually,
pay the premium.
Pay the premiums, and you negotiate on benefits, which the staff will actually enjoy, through that cover. Because basically what's happening is that the employees of KNH are about 6,000 of them. They come from different parts of the country. Their families are in different parts of the country. And therefore, if they don't have a cover that covers their families wherever they are, it becomes a challenge to them. The in-house one was actually, there to access this in-house medical scheme, within the hospital. But now an external cover will allow them and their families, to enjoy this. Okay. Therefore, we actually went ahead with my management and presented the same to the board, and the board approved it. So all the issues that have been raised, I had actually taken them, through the right procedures. I think the issue sometimes is that, as human beings, sometimes you feel that maybe you have been cheated or lied before for too long, that you rather, walk around. And I don't blame them for walking around. By the way, in fact, they didn't even go to the streets. They just walked around the hospital. They didn't go anywhere. In fact, they were just around there, going to our laundry spaces, coming back to accident and emergency, coming to my office. In fact, some of them even decided to come and have a cup of tea, with me. And then we went away again to blow vuvuzela. Yeah. So I think the point is that, and it was only for about less than 48 hours. So I think it is something that we can say they had issues, but we had already, as management, were proactive enough, not to wait, but to go through the requisite protocols and procedures of government.
So that is what was important to them or to the facility?
Yes, those are very, very important to them. Yes.
Because I'm looking at the return to work formula, and some of these areas, in fact, there were a number of areas that the union members were actually going on strike for. One, refusal to implement the CBA addendum of September 2025. There was an unsatisfactory medical cover we just talked about. Workload, where they say one nurse is serving 35 patients. And they say that is too much. A lack of stakeholder engagement on the Mwai Kibaki Referral Hospital transition. You'll tell us about that transition. Non-remittance of third-party deductions. You've been deducting money and not remitting.
Eric, that's not true.
Common cadre promotions. I think you talked about that. Pension deficit and conversion of the contract nurses to PNP. Now, talk to us about this issue of workload. Because that's a big one, right?
Yes.
What is the ideal ratio of nurse to patient?
Yeah, thank you very much, Eric. Thanks for all those questions. I think let me just even start with workload and the allegation that is 1 to 35. That's not true. It's a bit exaggerated. And I think you also know that when it comes to negotiations, you have actually to throw the stone inside a bush, to see what comes out of it. So I think, the ratios sometimes depend, with WHO ratios, and also we have got our national health systems ratios, which are basically between, I think, 20, basically 1 to 20, depending with the different specialties. In wards, generally, you can have 1 to 20. Sometimes, we have got ICU situations. We have situations where we talk about 1 to 3, whereby you have 1 nurse to 3 beds, but depending on the structure of the ICU. It's an open system, then you can have 1 to 3. But you also have very, very critical patients, where it is 1 to 1. You also have situations where we have got advanced patients, and I think also that one also requires, certain ratios. Kenyatta National Hospital is supposed to be a specialized hospital for very, very critically ill patients. And therefore, it behoves us usually to have, specialized nurses, across the board. And even that's why we also have specialist, consultants. Now, what usually causes us problems, in terms of management of our patients is a fundamental difficult problem that has been facing Kenya and national referral hospitals, the issue of the referral policy. The success of countries, when you talk even about Singapore, and even Uganda, for example, and I think Tanzania and South Africa, and even North Africa, Morocco. The referral policy is so specific, and so people comply with it, without exception. In fact, if you bypass the referral system, you are penalized financially.
What does that mean?
What I mean here is that even yes, if actually every citizen should be allocated a general practitioner, even should be given a primary health care facility to go to. You don't just wake up, my brother Eric, with a cough, and you start to imagine that you are very sick, that you have to go to Kenyatta National Hospital, or you go to MTRH.
But I live right there in Gomo. I live in Gomo.
Yeah. And my cough feels different. You still cough your kawaida.
I just cross over the bridge, the footbridge, and get to KNH.
Yeah.
So countries that have really effectively managed their referral systems have actually ensured that the referral system is, is complied to. UK, for example, I think UK has got National Health Service, which started in 1948 after the war, and I think when as we speak today, they still have challenges. And one thing that's very clear, you cannot go to a referral hospital without being referred by a general practitioner. So everyone must go to primary health care. You are referred only to national referral. And therefore, those are the numbers we need to deal with. But now, when it comes to KNH and I think our environment and in fact our ecosystem, health ecosystem, very well sometimes, in Nairobi, within Nairobi County and even Kiambu and Kajiado, sometimes there are industrial actions. When those industrial actions takes place, everyone walks to KNH.
Yep.
And particularly when you are talking about mothers who are to deliver. Mothers to deliver cannot change the date of delivery, and you cannot actually tell them that you have to go to, another referral facility. So when that situation happens, we have a capacity to manage about 40 deliveries a day. Under those circumstances, we sometimes have 80.
Oh gosh.
And these mothers also deliver babies. We have a capacity to manage about, specialized and serious conditions for children, for about 50 to 60 of them. Under those circumstances, we'll have 100 babies. That stretches, our nurses. That stretches our staff. And therefore, we have this intermittent, occasion when these things happen. But under normal circumstances, then it is possible for us maybe to manage with what we have.
So wait, just because you're answering the question actually, which is this ratio. 2,300 bed capacity. I'm assuming it's almost close to capacity most of the time, right? And then 2,000 nurses, almost legit. But then of course there's so many other people.
Stagger them into how many ICU specialists,
and like that,
so on and so forth, right?
But so you're saying on average, are we close to 1 to 20 or close to 1 to 30 or?
Yes, what I can say is that probably you can say that we have a deficit of about 400 nurses, basically. That's what I can say. And even for that reason, we have already gone ahead. In fact, we wrote to National Treasury, I think, a year ago, and they even gave us approvals to employ about another 100 nurses. And unfortunately, we have not yet money to receive resources. We are still pursuing on the same to see how that can be done. But I've gone ahead, in fact, to have nurses on locum, just to fill in this gap.
Yeah.
And therefore, as I've said earlier, it is useful also to appreciate that it's also not right to overemploy, and then it becomes a challenge, to the organization later on.
Yeah.
And so what has happened is that we decided to take an approach that when we have got huge surges, we have people on standby for locums, and when the surges go down, we can actually float them. But the point is that we have agreed we are going to have additional nurses to employ. The other thing is that, which is very, very important also, is that sometimes it's not the issue of the workload. Sometimes nurses are forced probably to undertake other, activities that are non-clinical. And what I did, for example, when I was in Jaramogi and even when I was in KNH in the past, what we did was that we were to bring in what we called health assistants. Health assistants, who will actually be trained, maybe for 6 months or so, in nursing duties, not necessarily nursing, but some basics, so that they can undertake some of those responsibilities, and then the nurses actually deal with the nursing duties. And that one usually reduces the workload. And that's what we are agreed even to have about 100 of them, going forward.
So, okay, I see what you've agreed here is that you shall continue to recruit locum nurses to reduce the workload. You shall engage with the Treasury to get money for recruitment of 100 additional nurses and 100 healthcare assistants.
Yes.
I still don't see where you have said that the 1:35 ratio as said by the union is erroneous. Because everything you've described there actually sounds like 1:35 is even not...
It's generous.
Yes.
But you can answer
like
that.
one nurse at KNH deals with 70
That's true. It sounds like the workload is bigger
It's much
than
higher
what
than
they're
that.
saying. But we'll come back and see if you can answer that after the break. And also whether this agreement will be honored, implemented, because I think a lot of the tension is we've done this before. Yes, we can see, to Mariam's point, there's a sense of different efficiency, but I think it's quite personal to a lot of them. Will we be honored the way we should be? But we have acting CEO of the Kenyatta National Hospital, Richard Lesiyampe, talking about the nurses' strike and what happens next. It's coming up to 8:30. Nice. We'll just get back into conversation in just a moment with the acting CEO of KNH, Richard Lesiyampe. Before that, though, here's some feedback on YouTube. Tibbs Muge, I think Mr. Lesiyampe spoke to this. What is the status of the machines in the hospital, especially cancer diagnosis? Then Moses Odindo says, KNH doesn't just consist of nurses. We have other staff. What is their plight? I think the focus today is on nurses, but we'll see whether we can get to that. Kindly ask the CEO about the transition at Mwai Kibaki Hospital, where KNH staff are also working, not just nurses, but other cadres. Then Kenneth I was going to say Meme, but it could be Meme. Our CEO needs financial support from government. He's spoken to having, waiting for a go-ahead from Treasury, right?
Yes.
And then there is the fact that visitors need to have physical IDs. This is Phillies, and leave them with somebody is old school and insecure. How have they automated that process? And then finally, Mulanda Brian asked our boss about the promised Halcyon radiotherapy machine that the ministry recalled funds and the status of the nuclear medicine unit procurement.
I think KU Teaching and Referral is doing nuclear medicine. Why not KNH? Okay.
He's taking note of the questions.
Yes. Yeah, thank you very much. Probably I can run through those questions very fast. Muge, on the issue of the status of the machines, we currently have revived the machine, the Linux machine that was down. Therefore, we have it running. 2, we are now getting a new Linux machine. It's already in Mombasa. In fact, it docked, I think, 4 days ago. We expect it to be in Nairobi within the next 1 week or so. So we're going to have a second one. We are also very grateful to our parliament, the parliamentary committee on budgets. They have also approved to give us a supplementary of 450 million to get another Linux. So we hope that we are going to get about 3 Linux machines, radiotherapy machines, to help our patients. I think that is something that I can say.
Sorry, how many does KNH require?
We require about 4. With 4 Linux machines, with the workload on cancer patients, and I want to tell you, Marian, we need really to face as a country. Cancer is a disaster. As we speak now, we are recording annually about 45,000 new cases. And the other sad story about it is that now we also have challenges on pediatric oncology, pediatric children affected with cancer. And therefore, it's a challenge. I think Odido said that, we are not talking about the nurses. I think, as I've said, all the issues affecting all the staff of KNH, we are going to address them, and we have started the journey of addressing the same. On the issue of Mwai Kibaki Teaching and Referral Hospital, Mwai Kibaki Teaching and Referral Hospital was under KNH tutelage, and the KNH has supported quite a number of hospitals, to become national referrals, including KUTRH today, and of course even supporting MTRH and now Mwai Kibaki. So Mwai Kibaki has been upgraded to become a national teaching and referral hospital on its own status with legal instruments, and it will be fully operational effective 1st of July. This year. And therefore, we have a ministerial transition committee between the Ministry of Health, Kenyatta National Hospital and Mwai Teaching Referral Hospital. And it has actually concluded on its report, and we intend to execute and implement it effective 1st of July. And therefore, I think that matter will be handled that space. I think Meme has raised the issue that we need to be funded. I want to say that healthcare is very, very expensive. And I think we need really to tell Kenyans that there's no free healthcare, and that's what is actually in the world. You look at countries like United Kingdom, healthcare is supported by taxes. Everybody is taxed. I don't want to say this in Kenya. Sometimes people are not very comfortable about it. Singapore, everybody is taxed, on this. Everyone must have an insurance. For us, I think it seems to be optional. And that's why sometimes it's very, very difficult. So the point here is that funding is useful, and we can't also blame government. Government has done so much for KNH. The 10-story tower there, all the equipment there, I think all these years, I think government has really funded it. But the thing is, things are changing every day, populations, numbers, and disease burdens. I think access to KNH, on the issue of access, I agree that we have to stop this paper thing, ID thing. We have to go digital, biometrics. And I think that is what I've said today, that we have started rolling digitization, and we're also going to do the same for those who visit us. We are very serious about security. I think all of us appreciate what has happened at KNH. And therefore, we don't want to compromise on the same. We are going to use whatever method for now until we get the biometric system in place. I think in terms of nuclear, the point here is actually talking about LINAC and I think the radiotherapy machines. And as I've said, we are going to, our nuclear science department is up and running, though not fully, and we intend actually to work on it to ensure that we also go for cyber knife like the way KUTRH is. And we also have to appreciate that we are not in competition here. I think the point here is just complementing one another. But the point here is that radiotherapy is very, very critical for us.
Okay. Anne Kathina is also asking about a lack of medication for pediatric oncology patients. Is that true?
Yeah, what I can say, thank you, Marian, is that let's also be honest and fair. KNH has done wonders and miracles. Sometimes, notwithstanding some of these challenges, that once in a while happens, we have done great. When it comes to cancer treatment requires not less than 50 different varieties of medicines. Different to different patients, depending on the stages of their cancers. And sometimes getting all the 50, in stock is not that easy. Not even for the private hospitals. And therefore, once in a while we have those challenges. But at the moment as we speak, we have the medicines, at least all the basic essential ones. And we are working towards, trying to not to have excuses why we should not have medicines. And what we are trying to do is that we want to bring the private sector. We have a private wing at KNH, and we want to support it to actually acquire a private pharmaceutical, outfit, so that they can actually stock all the medicines that we don't have, in the hospital, and therefore even patients can actually access those medicines from that point. So the point here is that we want to ensure that there will be no reason why we should not have all the medicines.
Is there a timeline for that?
Yeah. Okay, fine. I think it has a timeline. I think we already advertised. In fact, I think it was already advertised for next financial year. I think effective 1st July.
Explain that a little bit. Are you saying that you're going to have a private pharmacy operating at KNH?
No, what we are saying here is that we are going to have an engagement between the private wing and they advertise to have a pharmacy, being run by two of them, the private wing together with the private pharmacy. And we also have to share, resources, either 50-50 or 60-40. And therefore, some of the medicines that we cannot probably stock, in our facility can actually be stocked by the private pharmacy. Because what happened is that there are some medicines that are very, very expensive. I think sometimes we have a dose which is actually costing 70,000. It's not easy for us actually to have all those doses, I think in the facility. And probably the number of patients who require that probably are not that many. So what we are saying is that it's possible for a private entity to do that. But we are saying we need to have a kind of an arrangement between us, in terms of partnership, and we have a sharing model for the same. And these are some of the things that have happened even, I think, in terms of equipment. For example, I think in labs, we just get a placement of an equipment, we buy reagents from their supplier. Already government also has brought in another model of, they used to have MESP, now they have NESP, National Equipment Program, where, you get equipments and then, you charge fee for service, they get whatever percent and you get ours. Yes.
So it's that, because I'm just worried about access to this medicine when you bring in a private entity and the costs, and then who pays, whether is SHA going to acknowledge and appreciate that this one is, I'm actually buying from a private pharmacy,
Right.
whether it's within the private wing or whatever, within KNH or not. Right.
Yeah, those
So address the issue of cost and
yes.
access.
Yeah, I think you have mentioned the issue of SHA, and I just want to say that SHA is an universal health, program, and it's still in its formative stages. And we have an opportunity, for example, I think according to the laws, after every 2 years, we can actually review our benefits, review costs and all these kind of things.
Yeah.
And even, for us at the National Referral Teaching Hospitals, we have got certain things or certain procedures that are not done in any other facility. And therefore, those are some of the things that, they are taking on board, to review, some of their protocols, including even medicines. There are some medicines that you cannot find them anywhere else, or you don't require them until at National Referral Hospitals. And therefore, whatever medicines that we are going to have, we have got to call a formulary, at the National Referral Hospitals. Okay. And that formulary now we actually present to SHA to accept and, to accept it for reimbursements. So, but we are saying that we are doing it, we are starting it, slowly from July, and we will actually work and see how best it works for all of us and even for our patients. If there will be any challenges, we are going to review on the same. The point here is, we just have to find a mechanism to ensure that, our patients do not miss their medicines. We have also made arrangements now with KEMSA, and we believe government is doing everything possible to ensure that KEMSA has all the medicines, 90% of the medicines that we require in our national referral facilities. And therefore, that one also go a long way, really, to help our patients.
Where was that not happening before? What are the challenges?
Now, I don't want to speak on behalf of KEMSA, but...
Because I'd expect that, KEMSA looks at what's the demand of our health system, and then stocks according to the demand. If KNH have not told them, or if the health system has not said that we need a medicine called whatever, then KEMSA will not stock it. That is because they know nobody's going to take it.
Yes, there are quite a number of reforms taking place within KEMSA, and I hope one time you'll have the opportunity to have the CEO of KEMSA here. But we as National Referral, we have had a meeting, and we have discussed, we have picked on all the requirements we need, not only in terms of medicines and health products and technologies, but also in terms of other equipment. And we have presented the same, in fact, in a paper to KEMSA and also the headquarters. And we believe that this will go a long way, actually to alleviate this status. The thing is that, KEMSA also, the little I know is that it has also supplied medicine even to the county hospitals, and so many other hospitals. And they have not been paid. I think some of those challenges probably, are faced them. So they need to come with a mechanism on now to ensure that they stock 90% of the medicines and they also recoup, I think, when they sell.
I want to piggyback on this question and you've mentioned it a bit on the question by Sons of Kronos on the transition of the Mwai Kibaki Referral Hospital. Please tell us about that. Because yes, there is a hospital in Udhaya called the Mwai Kibaki Referral Hospital. Yeah. It was a KNH facility. Who is it transitioning to? And why?
Yes,
when you say it was a KNH facility, you mean like branch at KNH?
It was an annex.
Yes, it was an annex of KNH. Yeah. So, and it was an annex of KNH, and therefore all operations of Mwai Kibaki, including payment of staff salaries, and even their budget and even their procurement, was done under the aegis of KNH. But government elevated it to become a national teaching and referral hospital. I can't remember exactly when, but I think the last 4 months or 6 months. And it has a legal instrument, approved by Parliament and the President. So they are
it's its own level 6
it's supposed
now.
to be its own level 6. And already as we speak, they have got their own board, they have got their own chairman, they have got their own CEO, running the facility. But it happens that some of the assets belong to Kenyatta National Hospital.
Okay.
It also happens that some of the staff belong to KNH. And therefore, that's actually the transition that we are talking about.
Okay.
And as I have said, there was a committee that was established by the PS in charge of medical services, Dr. Umu Luga, and it has completed its report, and therefore the transition will take place, before to be effective by 1st of July. So there are some staff, I think, let me just be honest about it. There are some employees who feel that they have to come back to KNH. I think
They
that's
don't want
scary.
to remain.
They don't want to remain in all
They
that.
don't want to be absorbed.
So I think
They don't remain in
and this one also has to be done, in a structured manner.
Yeah.
Because
Right.
you can't also
Fair.
have everybody coming out of Odaya and
Yeah.
we leave it, running
Without any-
So was
What
that the
was
bone of
deal?
contention?
Yeah, what was the
plan,
deal, the
yeah.
plan? They were going to Othaya, to Mwai Kibaki. Was it like, hey, you're going to be seconded to Mwai Kibaki Hospital for the next 2 years, for the next 6 months? What
Yeah.
was the communication?
I think no one envisaged that, Mwai Kibaki was going to become a national referral and teaching hospital. So it was just a satellite of KNH. So the issue was that we transferred a number of staff to go and support, the services at Mwai Kibaki. The same thing we also did at Korogosho. Remember, we also had Korogosho under ourselves, and, we also had the staff who went there. Also, the Minister of Health actually even supported us to have some staff in there. So the point here is that now the issue is how do you handle, the staffing, when now Odaya is transited to become a national referral,
separate entity.
and a separate entity, what happens to the assets, what happens to human resources,
Yeah.
and what happens to these things. So
And,
that's
and the nurses here are complaining that there was not sufficient stakeholder engagement. What does that mean?
will not matter.
Stakeholder engagement, the same one.
Oh, in
One of the
Mwai Kibaki.
reasons for the strike, yes,
Yes.
was that there was no stakeholder engagement on this transition.
Now,
Because it's one of the grounds that they've gone on strike.
Now,
What do
one
they
thing
mean?
I can say is that, I think when it comes to stakeholder engagements, I think all of us have never agreed on, what is 100% stakeholder engagement or public participation in this,
What's the sufficient level?
Not sufficient and not sufficient. But one thing I can assure you is that that committee has been there. In fact, they have got representatives from Odaya, my ministry, and also my Kenyatta National Hospital, and also the Minister of Health. And they have actually met staff, I think on 1 or 2 occasions. They have also engaged us, in fact, I think at the board level. And we have not executed and implemented anything. So if there are issues that they need to bring up, we are ready actually to engage and see how that's one can be ironed out.
I know that we, having the acting CEO of KNH means we will ask a broad spectrum of questions beyond just the ongoing strike. And I think we'll continue to do that even in the next hour. I did want to come back a little bit to the nurses' strike. You said that they've returned 7:30. What is being implemented today? As per the agreement, as per the return to work formula,
Yes.
what's different for them starting today? I know some things may, roll out gradually, but what is being implemented today, this coming week, that will begin to speak to their concerns?
Okay, fine. I think, thank you very much. One of the things that we agreed yesterday was that in the interim, before we have this medical cover that we are going to procure for them, come effective 1st of July, we have made an arrangement whereby, in our private wing, they're actually going to access the services there. Previously they were actually accessing services within the main hospital, and I think that one is effective today. And I think it's already agreed on. I think the other things that I think we have mentioned here is the issue of promotions that we are saying that are going to be effective on 1st of May. I think it is 30th of May, and we are going to do that. It's actually a month. It's actually a few weeks from now. I think in terms of the others, I think most of the majority of issues actually effective from 1st of July. And we are taking action on that. I think the other one was on the issue of, which I've said it was historical, was actually on the issue of the pension deficit.
Yes.
And I think sometimes it's good to put this into perspective. The government of Kenya transformed the pension landscape in 2010, and all public institutions which had a pension scheme or a pension structure were converted from what we call DB, defined benefit scheme, to defined contribution scheme. And KNH was one of them. And they actually transited, I think, in 2012, 2013. And therefore, these defined benefit schemes have actually been, they're actually supposed to be exited, I think within the next, for KNH, I think by end of next year, I think that will be the last man or woman who is actually on that scheme.
Okay.
But as we speak, there are about 1,000 of them who are on pension on that. What usually happens is that most of these DB schemes, it's very difficult sometimes actually to fund it because one, employees are all exiting and therefore there are no contributions coming in, and therefore the funding deficit usually, accumulates.
Yes.
So that's actually one of the reasons that they had a challenge. And this thing has happened for the last 10 years. So it's not something that happened yesterday. What is critical for management and critical for organizations is actually to ensure that, no staff, who retires, who is on that pension, fails to get their pension.
Yeah.
I think that's basically, and one thing I've committed since I came, and I've actually ensured that that has happened. I'm also working with the new board of trustees of the scheme to see to it that, we also look at the assets of that DB scheme to see whether some of the assets can actually be disposed, and probably other assets can actually be added more value. Because our DB scheme is probably, should have been one of the richest, in the country. We have wonderful buildings. We have one, we have an old estate, somewhere in Govt. We have another one, in fact, in Nairobi West, in Westlands, a whole great facility there. We have even land in Kajiado.
Will
So the point here is
liquidated.
Yeah, so some of them have to be liquidated, and some of them, probably require to be added more value, so that we can actually have liquidity to ensure that until the last man or woman on the DB scheme, leaves the scheme. So that one is something that I have actually assured our staff, and nobody, as we speak, has the same challenge. The other one is the issue of remittances. And
I was about to say.
Yeah, so
because you can say that. We're doing all the statutory deductions, but it's a very common story in the private and in the public sector. The day you need a tax compliance certificate and you're going to KRA, is the day they tell you, actually, and payee.
We haven't been receiving a payee.
And you're like, no, but from my side, 30%, 33% was gone.
Yeah.
It just wasn't remitted, and so on and so forth for SHA, for pension schemes, and sometimes even for
SSF.
loans and SSF. Yeah, it's madness.
Yes, yeah. Fine, let me just say this. I agree. Institutions have challenges in the remittances. But one is very, very important to put your employee first. It is very, very wrong to have an employee's remittance on a loan not being remitted. The penalties, that follow, the stress, I think is something that's unacceptable. It actually affects, even their work performance. So what has happened is that I think for us at KNH, for example, and I think also maybe I'm not talking on behalf of my other facilities, natural referral hospitals, is that we have also not agreed to actually accept new changes. And sometimes I think failure to accept changes, and have culture change, culture orientation because of new dynamics. So because one, prior to SHA coming in, what used to be happening is that we had the NHIF, and with NHIF, you probably get your monies, after every 1 week, after every 10. Sometimes you don't even have to have patients who are on SHA, you actually get cash, and therefore I think liquidity, was actually probably very, was good. But now I think when you actually move into universal healthcare, and actually that's what has happened globally, you usually have one central single purchaser, and that's what happens with SHA. So what has happened is that SHA is, we are making sure that all our patients actually are on SHA. And therefore, all our resources, will
come from SHA.
Yes.
Now, SHA has come out with a policy that they should be paying, on 14th of every month.
Okay.
So unlike, when before, probably you could be getting it on a weekly basis, or maybe even on a monthly basis by that year.
Yeah.
So what should have happened is that we should have actually picked on that, I think, instead our staff, informed everyone, and therefore started to work on a formula whereby everyone knows that, we are going to get my monies before or by 15th of the month. And therefore, if you take a loan, you have any other commitment, you do what you actually fix, your check off from that particular date. So this is actually what we have agreed yesterday with the union, that we are going to sensitize. Of course, me, I've tried to do it since I came back, I think I came to the hospital, sensitizing on my staff that, I think most of our resources will be coming from SHA and will be coming from 14th. We also get a government exchequer, and also government exchequer also comes from 5th to 10th. So all our money is actually between 10th and 15th. So the issue here is that we need actually to change our orientation, change change the way we manage things.
The landlord is knocking on the third. The landlord is knocking on the third.
So I think these are some of the
I think it's for the facility
Yes.
to change its month.
Yeah.
So that your month begins from the 15th to the 14th.
Right.
All right? So at the end of the month, you pay me my salary at the end of the month. I will take care of my rent at the beginning of the following month and all. You work with your month being 15th to 14th. When you get your money from SHA, from Exchequer, 15th, be ready that in a week's time, you're paying salaries. And within the next 7 days or so, you are remitting.
So that I'm not affected.
So I'm not affected.
I agree, Eric, but I think sometimes you have to face the reality.
I can now start receiving my salary on the 16th of the month.
So that's,
It disrupts my plans, Kapsa.
But I think what I was saying is that there's room for engagement.
Yeah.
Probably, for example, even with the banks.
Yeah.
You know, that you can also have, we have had banks which we have engaged with for the last 50 years. Kenyatta National also has been in existence for 125 years, you know, providing services to Kenyans and the world. And we are banks, you know, or rather institutions which we have been engaging with. For example, I'm a member of Matibabu Sacco myself, you know. Though I left KNH 13 years ago, I've never
Right.
left that Sacco.
Yes.
I'm still a member there. And I also find it very difficult for me to have my delayed remittance, you know, to Matibabu Sacco. But there's nothing wrong to engage the banks, engage Matibabu Sacco that, you know, if I don't pay, you know, within 15 days, please don't penalize my staff.
Okay.
You know, I think there's some engagement that can be entered into.
Yeah.
I also know that some arrangements have been done in other institutions whereby they even agree that, you know, you pay all my staff by 30th. You know, my pay or my check will come by 15th. If I delay, then penalize me after the 15th. You know, these are some of the things that I'm saying.
Conversations that you have.
Conversation should be-
Before we take this break, still on the issue of the delayed remittances, one of the things that you've said in the return to work formula is a meeting will be convened on the 15th of next month with financial institutions to address penalties charged and to ensure staff are not surcharged in the event of delays. And the union is to submit the list of staff penalized by financial institutions as a result of delayed remittance. How are you going to do that? Because yes, we in fact even carried the stories of some staff members who are saying, I have already been penalized by
My bank.
my bank, my SACCO for delayed remittances. So how are you going to do this? Is the hospital going to pay the penalty on behalf of the staff?
I think, let me say from the onset, it's not possible, it's unacceptable to pay penalty to anyone, you know, I think as an institution. Because what usually happens that those arrangements actually between the employer, the employee, you know, it's a private arrangement. You know, we only come in as a third party to, you know, to give the salaries. But what we are saying here, I think, let me finish. Yeah, it's a private arrangement.
Premised on
A promise that the salary,
will come.
I agree. I agree.
Yes.
The point here is that a number of banks, I don't want to mention which ones here, and they have all said, you know, we have not penalized anybody. Probably one or two, and probably the numbers are very few. Those are the cases we are saying. Why don't we get the list? Let's get the list. Let's get the evidence. Then from there, then we see.
Say you get a list and it's 5.
Yes.
You tell us
What will
after
you
the-
do about those 5?
But tell us after the break. Because we need to take that break. We are still going to be hosting Richard Lesiyampe. I think a few people also want to call in. The number, let me refer to Mariam for the number.
So we're going to speak to the union,
Yes.
the Kenya Union of Nurses and Midwives. So we're going to hear from them as well, you know, reacting to some of the issues and also talking about them speaking to their members as well directly on this return to work formula.
And also to the general public
Yes.
as well. 0719 038 858. That's our number. 0719 038 858. We'll be right back after this.
Yeah.
Our conversation continues with Dr. Richard Lesiyampe, the acting CEO at the Kenyatta National Hospital. The nurses who were on strike for a couple of hours have decided and signed a return to work formula. And now from the union, they have resumed work this morning. And Dr. Lesiyampe has been walking us through what are some of those issues that brought them here. Some of them were historical things that he inherited, and he's saying we are working to resolve them, including increasing the staff at the facility, not just nurses, but all round, including looking at the welfare of the nurses who are working. But then union leaders have also been on this particular conversation.
Right.
And, we are going to hear from one of them. And this is Dr. Gisenyi, who is from the union. And
No, he's a nurse,
no,
I'm assuming. I would assume he's the secretary of the Kenya National Union of Nurses.
yes, Lina Gasenye,
Yes.
the secretary of the KNUN, the KNH branch. He's with us on the line. Linus, good morning.
Good morning. Is that Latif?
Yes, it is, Linus. Asante sana for speaking to us. We also know that on the line is Seth Panyako, the Secretary General, the National Secretary General of the Kenya National Union of Nurses, and he'll be speaking to us later. But Linus, let's start with you. The return to work formula that was signed yesterday contains, signatures from the leadership of the union. Is yours one of them?
Yes, it is.
All right. So one of the questions that Janet had asked before we closed the hour was these issues that you agreed on. What did you say you wanted to be implemented immediately? And what are you comfortable with not being implemented immediately? Like maybe coming up in the next few weeks or in the next months?
Thank you, Latif. And first, you have said my General Secretary is online. Let me salute him for the leadership and guidance that he has given to the union, and more so to KNH branch. Thank you, Bwana General Secretary. First, I want to say that there are quite a number of issues that are affecting our members at KNH that we went with on the table, and we're expecting to get solution from the management and the government at large. And as you have put it, not all the issues could be solved as immediate as we wanted, and therefore we staged them on how to solve them. Mm-hmm. And one of the issues that was to be solved immediately was the issue of remittance of third-party deductions. Mm-hmm. You know that as employees, sorry, Latif, my voice is a bit hoarse.
It's all right.
But I've been singing for the past 2 days.
We can hear you well.
Yeah, we can hear
Solidarity,
you.
brother. Solidarity. We're fine. We can hear you.
Yes.
Thank you. So as I was saying, as employees, we do take loans. We do take loans from banks, loans from SACCOs, loans from different organizations. We also committed our payslips to insurances to cover our families. Mm-hmm. We have several commitments on our payslips. Mm-hmm. So these commitments have been deducted from our payslips by the employer, but they delay to remit them to where they're supposed to be remitted. Mm-hmm. So this was one of the thorny issues that was affecting our members.
Okay. So
on the table, I'm glad to report that the management, since they received our strike notice, they have been running up and down to try and sort that matter. Mm. So on Monday when we went on strike, what was pending was the remittance for January, and remittance for January, February, and March. Mm-hmm. So by yesterday, when we were signing the return to work agreement, they had remitted deductions for January, they had remitted deductions for February, mm-hmm. and there were evidence to the same. We were given evidence to the same, mm-hmm. and the deduction for March, there were commitment that they will be remitted by 23rd of this month. Because we also understand that our employer gets funded from the exchequer. So at times this disbursement of funds from the government gets to our employer after 15th of every month. And that's why we were in agreement that it can be done by 23rd of April. That is the remittance for March. The other thing that was to be handled more immediately was the issue of medical cover to our members. We know that we have a medical cover provided by KNH as an in-house scheme. However, our members had been restricted not to access specialists or consultants when need be. Okay. And this has been affecting our members. So by yesterday, we had a deal that our members will be allowed to see consultants or to be seen by consultants when need be. Okay. As far as their medical cover is concerned. The other thing was accessibility to medicine, in that our members, whenever they are sick or their families, some medicines could not be available to them But as per yesterday, we had an agreement that all medicine that our members require will be accessed. They'll be allowed to access whenever they are available in our prime care center, just like any other client. So that is a win for us. We also had a common card promotion delays. There are our colleagues who are to be promoted right from December, January, February, but this had not been done.
Yeah.
So we agree with the management that this will be done, although not immediately because the payroll for April is already closed.
Okay.
So it will be done from 1st of May. So from 1st of May, all our colleagues who are due for promotion will be promoted.
Linus, let me ask you.
Yes,
all the issues that you're mentioning here, remittances and which are being sorted out immediately, in-house cover being sorted out immediately, access to medicine, and so on and so forth. Did these things have to get to a strike? Are you saying that you had not raised this issue with the management and discussed them with the management before the strike?
We have worked with the management, as I've said, since December. We have been working with the management. If you remember, I don't know whether it caught your eye that we issued a strike notice in February 17th, and we engaged the management. We were directed by the Ministry of Labor to go to sit under a conciliator in the Ministry of Labor. We did that for more than 2 weeks. So those are issues that we have been working with the management. Short to say, but as you know, the way the government works.
No, I don't know. Maybe CEO, you're here. I mean, since February when they issued that strike notice.
You know, at times the government you raise issues and the management forwards the government, and maybe at times the government does not look at it as a priority, and so we had to get all onto this.
Yeah.
We had to go to get our members out.
I hear you.
There's
There's a former leader of the Doctors Union who had said that the only language the government understands is a strike.
Is a strike.
That former leader is the current Principal Secretary for Medical Services.
Yeah. But hold the line, Linus, because we just wanted to engage Dr. Lesiyampe based on something you've just said. Hold the line. We want to continue engaging you. So I think, Eric, you were asking him.
Yes, since February.
Yeah, thank you very much, Eric. And I also want to thank Linus and the leadership of the nursing union. First of all, we have been having very, very good engagements even in the past. The issues that you have mentioned, actually, truly speaking, are very few. And the spectrum was actually bigger. It's not the issue of those 3-4 issues. I think we have issues which go back up to 2017 return to work formula.
Yes.
There are issues that are concerning the budget, the pension scheme which goes back to 10 years. You know, I think the issue of the nurses, I think the workload, I think also some of the critical issues which were there. So it's not only these two. There are 3 or 4 things that you can actually iron them out. But I think there are some issues probably that required more consultations, required other interventions. For example, I think he has not mentioned the issue of the workload. What happens that because of our specialized nurses, we lose seriously, a number of specialized nurses to Europe.
Yeah.
And it's very, very expensive to train a specialized nurse. At KNH, for example, we have nephrology nurses. It takes 2 years actually to train them. We have critical care nurses. It takes 2 years to do the same.
Right.
And I think even the last 3 months I've been around, I think I've lost about 40 of them.
Wow.
And therefore, sometimes it becomes a challenge to replenish them at a go. You actually have to go and negotiate, agree with the ministry that you are going to employ them. And therefore, sometimes some of these things you have to go back to the ministry. So there are some issues that probably we could have sorted them out, between among ourselves. There are issues we have to escalate outside, KNH. Yeah, thank you very much.
Okay, we'll get into a conversation, into a call with Seth Panyako as well. But when we finish that, I want to get back into the funding of KNH, exactly how it's done, because 40 nurses in 6 months is alarming, but it's also systemic of how much brain drain we're suffering. And we should not be ideally losing such talent to Europe. I think Kenyans deserve, that good quality of healthcare. Yeah. But we'll talk about that in just a minute. Let's go onto the line with Seth Panyako, who is the Secretary General.
Before Seth comes on,
you want to finish with Linus? Okay.
I just want to ask the final question to Linus before we let you go, Linus.
Right.
What would make you go back on strike?
What will make us go back to strike is a difficult question, but also to our union is a very easy question. When this implementation is placed under the table, then it will make us go back to strike. Let me tell you that the issues that we left or we gave them like long term are not very long term. The issue of our CBA. You know that when we go on strike, there are times that monetary issues like the salary increments. We had about 3 issues on CBA that are touching on salary, and our members are very expectant. But we also understand that this issue of CBA has to be forwarded to SRC for approval. That's the Salary and Remuneration Commission for approval. So the delay, it may be from within, but we don't want to speculate. From within, we can monitor, but delay from SRC can spike or can trigger another strike. Active. Thank you.
Asante. Thank you very much, Linus. Linus Kasenye is the secretary of the Kenya National Union of Nurses and Midwives, KNH branch, one of those that signed the return to work formula yesterday. Shortly, we shall be getting Seth Panyako, the National General Secretary of the union. But then, Dr. Lesiyampe, if you say what would bring them back on strike is if you don't implement first this return to work formula fully, and then also when they look at what they've already signed before, if you don't actualize them, they're back on strike. Which is it's the constant.
It's the constant, and in fact, what is and I'm sure Dr. Lesiyampe will say either he's alluded to it or he said it should by now be seen that it will be honored. But for a lot of them, they're saying we've heard that before. I wonder what it takes to fully honor such agreements. I know you've talked about resourcing.
I think I know the answer. It's honoring an agreement.
What do you mean?
Call me crazy. To give faith.
What it takes to honor, just honor.
To honor
the agreement.
But maybe Mariam, there's a limitation to honoring. Maybe honoring is relative.
I think, can I be honest? It's who are you negotiating with? If the things that are within your purview and within your doing are done, that sends a signal. If it's the exchequer didn't send money, that's a different story, you know. And then you can say, hey, you guys, if it's Dr. Lesiyampe and the leadership and the board of KNH, they did this and this and that, and they have kept up their end. If government didn't send money, then that's another conversation. But there's goodwill from at least your board and your CEO, and so on and so forth.
I feel like the goodwill, because they'll say, but will the goodwill pay my rent? So what is it that is that stops one from honoring the agreement? You may have alluded to it in the past hour or so, but what's the 1 or 2 things that you say this keeps coming up and this might compromise the agreement?
Thank you very much, Janet. I think one thing I can say first is that my current PS for medical service, Omo Luga, and therefore I think he has to make sure that we don't have another strike, because he has also agreed that the only language that
government understands
is a strike, and he's actually now in the government. He's actually the PS. So I think he's definitely going to support us to ensure that we actually execute this plan. One thing I can say is that personally and my team, we are committed as management. And I've been on record, and when it comes to issues of human resources, the issue of staff welfare, even in the past, that I go out of my way even to implement things that they have not asked for, I think because of my orientation. And therefore, we are committed really to ensure that this is done. There are some things that probably require interventions by SRC, and we are actually going to ensure that we follow up on this. We did it before in the past. The only thing that is actually, they said, for example, I think on 1 or 2 items on the CBA is that it has to be put into the future CBA that is actually from July. So, and I think that's where probably we had a conflict between us and the union. Because the union wanted it to be implemented now, but the SRC said that, no, put it in the next CBA cycle. So we intend actually to push for that. I think in terms of resources, I think it will be upon all of us at KNH, not only management, but even the staff. If we all put our hands on deck, provide quality care to our patients, make the patient the center of our business, it is possible for us actually to generate substantial resources that can actually help us, to sort out some of these things. And therefore, it's not to be an issue of either the union only or management. I think it should be something that a clarion call for all of us. But on my part, we are going to execute. We are going to implement. We are going to ensure that we go out of our way to make sure that this return to work formula, does not take us to another strike. Okay. Similarly, I also want to see to it that, other unions, for example, other issues like the KMPDU, we also have KMPDU at KNH. I think a few areas or a few issues that are affecting them, we actually going to engage to ensure that, we resolve them probably before it actually turns into a strike. Similarly, we also have the clinical officers, we also have the laboratory technologists, we also have, in fact, other staff, including non-technical staff. Yeah. The point here is that our institutions must also be efficient, levels of efficiency, and also focus on their customer. And I think that's the turning point, of every organization. True. And I've rallied my staff, I've rallied my management to see to it that, we provide quality care. The other very important thing is that I'd like to say is that the issue of having equipment, we have equipments, instruments, and we want to appreciate the government by introducing the NESP system, and the former MES. I think for your information, and even probably for Kenyans, I was in the government, I think, from 2013, and it happened that all of us appreciate that healthcare is very, very expensive. You can imagine, I think, in 2013, getting an MRI, a scan, was probably costing about 35,000. A CT scan maybe about 25,000. And the only way to bring that down was that government decided actually to have MRIs, and CT scans in almost every hospital. Of course, it had its own challenges, but they were there. Yeah. And by that fact alone, it brought down, the cost of a CT scan. It brought down the cost of an MRI. And I think when you look at the benefits, to maybe 20 million Kenyans who go for it, I think it is something powerful. Yeah. So what has happened now, for example, I think the LINAC we are getting a LINAC through National Equipment Service, a LINAC, because a LINAC machines cost about 300 million. Wow. It's not possible for even maybe government to buy all the LINACs. But if you can get it, what is important is that probably sometimes you might not make any money out of it. But the service to the Kenyans, I think the service to those people who are suffering from this cancer will actually be more powerful than even the money itself. So I think it is useful also to appreciate that the equipment, and I think as we speak now, recently we had 50 children, who are hearing challenges. And we actually had the cochlear implant for 50 children who don't hear. It has never happened in this world, or in this part of the world. And as we speak today, those children have shown signs of hearing. It is a life-changing thing to their mothers. And we really want to support even the partners, the Moroccan and even the First Lady, Mama Rachel, who actually supported us on this. And therefore, when we do those great milestones, definitely it's going to give us traction, people to have confidence in us, and also, confidence with the experts we have in the hospital.
Definitely a good push. Sorry, I just wanted to get into the funding, because you've even touched a little bit on it. You're right. 300 million shillings for one piece of equipment is a lot. How does KNH get its funding? From Exchequer, Is there any situation where someone is charged while at KNH, and so on and so forth? But let's start with funding before we now go to the customer experience.
The national government of Kenya, funds our national referral and teaching hospitals, and specifically they fund for personnel emolument, salaries of all our staff. Government of Kenya funds on a monthly basis, on an annual basis. It also funds us on equipment, what you call development, and generally on other terms. So I think for us, what has happened is that we've been having a budgetary position of about 15 billion shillings annually, in terms of our budget. Partially, I think about 13 billion, comes from national government. And then the balance, I think, comes from also our internally generated revenues. So
your internal generated revenue is about 2 billion.
Sometimes we go to it was less between 2 to 4 billion, 2 to 4 billion, depending on in a particular year. So the other funding is that we provide services, and with those services we actually get reimbursed from through SHA. And on a monthly basis, we charge or we claim between 250 to 300 million Kenyan shillings. These are services we have offered to Kenyans. And commodities, health products, surgeries, and all those kind of things. And on a monthly basis also, reimburses us, and also on a monthly basis, government gives us exchequer. The only thing that I can say is that there are no enough resources. You will never get enough. You will never say that this is enough. But I think what is very, very clear is that how prudently do we use the resources we acquire. Very importantly also is that where we have got gaps, we also need to get our partners, and I think as Kenya, we have also been sometimes having support from donors, and we have substantial number of donors who come and support us. We also have, other philanthropists. As we speak now, through our board, we have got about 9 wards that are being renovated, and renovated by, a private sector. In fact, we have Absa Bank renovating, Safaricom Foundation, we have Equity Bank, Cooperative Bank, and we're also looking forward to NTV, probably even to take one ward, I think in the future. So we also get some of this, and some of those supports, we actually document them and actually recognize them, as funding to the hospital.
Yeah, they are. So this 15 billion shillings annually, does it come as a proportion of the healthcare budget? How is the line item? And has it been increasing over time? Has it stagnated at 15 billion? And in your view, or from your board and from your structures, how much is required to run Kenyatta National Hospital optimally?
One is that the envelope usually is that the government cycle or financial or budgetary cycle is actually annual. And it's actually done in sectors. Yes. So what happens is that the Ministry of Health has a sector, probably Department of Medical Services gets about 105 billion annually. And then with the 105 billion annually, we all go and sit down, and now negotiate, who gets what is the priority and this kind of thing. And in most cases, I think not all of us will get what we want. And I think this was very important to the union. You cannot not win 100%. Usually in negotiations you get 60, 40, or you get 80, 20, and then next time you get something else. Yeah. So occasionally we have certain gaps, and for example, I think the few challenges we've had currently is that the issue of the gap of personnel emolument sometimes, our establishment, for example, sometimes about for nurses 2,300. But when we actually have challenges, we bring in about 200 or 100 locum nurses. That one now gives us a challenge because the government probably might not fund it, but we have to fund it from our own internally generated resources. So we can say that government has provided us funds, we can say adequate to some extent, but occasionally we also have challenges, in terms of those resources.
Let me ask a question in a roundabout way. When the sector working groups are presenting their numbers, you as KNH, you say, I need this much for equipment, I need this much for emoluments, I need this much for paint, I need this much for surgical spirit, and then you give that number. Yes. What number do you give?
Yes, we gave a figure of about 18 billion. Yes. Okay. Yeah, but we are actually somewhere at 14, 14 billion. So a gap of about 4 billion.
So 18 is what you need to run the facility?
Yes, we are saying that 18, is optimum. Yes. Okay. Yes.
So you're okay. You're okay.
You're okay. There's 4 billion less, but they're
no.
What do you mean?
They received 13 billion from the National Treasury, and they can raise up to 4 billion.
Depending on the situation.
Right? Yeah. Now streamline your situations.
Yes.
If you streamline your situations, you can raise even above the 4 billion shillings, right? Which means that you can actually operate on at budget, or you can even run at surplus.
Yeah, it is possible. That one I can assure you, it is possible.
What do you need to
the
get
only
there?
thing that, what I need is that I think, as I've said, one, I need to automate the whole hospital. You have to digitize. I think that one can create efficiency. Similarly, I think we also have equipments that are very, very critical. For example, I think the LINAC. We have been having a challenge with the LINAC, going down. And with the LINAC, for example, I just give an example, is that on a daily basis when our LINAC is operating, we serve about 120 patients a day. Sometimes even 1 or 2 shifts. When it is down, and sometimes it has been down for 3 months, you can imagine, all that revenue and, all that actually disappears. Besides the fact that those patients are affected and they suffer. Okay. The other thing is that, as I've said, is that it's also useful for us actually to look at the issue of productivity. Productivity sometimes is a very, very evasive thing in public service. I think presence, who is present between that 7:30 and 8:30. Yeah. Which which theater is cancelled and which is not cancelled. You know, some of those productivity indicators are also very, very powerful, and it is also very, very important. The other thing that needs to be, you know, fixed is the issue of procurement. You know, procurement. And I think all of us have to appreciate this. Sometimes we have a procurement that is inflated, you know. Sometimes we have procurement that, you know, we get a poor quality, you know, of items. And some of these things have to be cracked, you know, because you can buy an equipment, you know, a poor quality equipment, and 3 months down the road, you know, it's dead, you know, and it's not acceptable. So sometimes also putting in mechanisms to ensure that we get the right equipment with the right quality, you know, and enough of them that can actually provide us, you know, with the services that we require to provide to Kenyans, and therefore we can also make money out of that. The other very important one is the issue of research and innovation. Yeah, I think I can't ignore that very, very important fact. Most of the hospitals in the world, you know, and I think teaching referral hospitals have made their monies, you know, through research and innovation. And I think this is an area that we really need to put in a lot of effort, you know, as Kenya. And as you can see, you know, countries like South Africa, you know, Morocco, and the rest, most of the hospitals actually are not even funded by government. You know, they actually fund their own, you know, services. And this is actually through research. And we have now put in a robust research department. I think it was there. I'm just trying to, we are trying to build up on it, to, you know, to have a proper grant office, get, you know, bankable proposals, encourage, you know, employees to undertake this research. And we believe very strongly that that will also give us another great avenue. So we can say that our ministry has done its best.
Yes.
But there is always room, you know, to get us additional resources. You know, there is also room, you know, to support us. You know,
the ministry should put you on notice, actually. You know that in the next 5 years we are going to start reducing how much we put from the exchequer into running KNH. You should find ways of funding KNH through innovative ways, innovative resources, your quality of service, and so on and so forth. Like you've said, other research facilities globally don't actually even need that government exchequer.
I would say before that, you have to put in, because research is you give and then you get, especially with research and innovation.
Government has given to KNH for 100 and how many years?
125 years.
125 years, Mariam.
They've given for ukona homa shikadawa, not for research and innovation.
Yes. Yeah. You know, that will be another arm. The research and innovation will come from a different, Nacosti and others funding. You know that, and that's for Dr. Richard Lesiyampe and others who come in after him to think of how they engage with the research side of government, but not coming from that direct budget of the Department of Medical Services, funding to employ staff and to pay for stima Kizimwana Care and Power.
Yeah, just to pick you on that, we have a private wing at Kenyatta National Hospital, actually level 10 and 9. And that facility, we have actually given it more autonomy, you know, because it can actually, you know, provide services even to those who are people who have got private insurance, you know, and you know, manage it as a business unit, you know, and with that business unit, it can actually generate substantial resources even to support us, you know, in the main hospital. And therefore, we are exploring, you know, several avenues, including issues of outsourcing of services. You know, sometimes you don't have necessarily to have, you know, to have cleaners. You know, you can actually outsource those services and use on this. You know, laundry services, you can also do the same. So we want to explore those. But I think, as Marian has put it, probably we need some small injection, you know, some small capital, you know, to kick us off, and probably get a time frame, you know, why this should happen. And I think, as I conclude on that, we have some milestones also that can sell us. You know, I think you remember the boy Brian, you know, the one who had lost the whole face. You know, and we did that world class. You know, I think maxillofacial reconstructive surgery. You know, and it was just done by our specialists. Because at the end of the day, what we have is actually we have the best specialists, very great trained fellows, and including our great nurses. The point there is that they can actually do any, you know, human, you know, reconstructive surgery. They can even perform, I think, some of the great things that probably have not happened in others. For example, I think you remember we had an individual who cut his hand, you know, and we also had incidents whereby we have had a penal cut, you know what I'm talking about. Today, as we speak at KNH, we have the only facility with a microscope that can actually help us to do intravascular surgeries, you know, to return that hand, you know, get through those veins, you know, connect them, and the hand performs. Even with a penile, can actually be put back, you know, if it's brought, you know, on time, you know, through some certain conditions, and that can happen. So we are saying that with such world-class milestones, it can actually even attract us to have, even patients internationally, regionally, and we can actually make
that's definitely not in dispute. I don't get surprised by our milestones. Like our people are those people. It would just be. It would honor them to ensure that they're doing it in the best possible standards, I think, and comfort. The memorial home, I'm just trying to think about diversification. Right. How long has that been there? I'm sure it's been there for a while, but it's kind of like the new Kenyatta Memorial. You know what I'm saying?
The funeral home.
The funeral home.
Kenyatta Memorial Funeral Home.
The morgue.
Yeah, I think
it's very modern, state of the art. I'm just trying to think of ways in which it's more
From a revenue.
Yes, Mariam is like, wow, because as somebody who has, sadly had to go there a few times over the last few years, I remember just thinking to myself, this is really state of the art. There's a lot of dignity, there's a lot of top class service, cleanliness, professionalism, and it's packed. And yet, even with all of that, people just come and go. Yeah. But I'm like, I know. I think the journalist in me was like, this is also revenue.
It's a revenue thing. If you think about it, our state funerals, we don't actually pay for these services to public sector. We pay services to the private sector. Leave funeral home.
Yes.
If KNH had a world-class facility that,
But that's what Jano is saying, they do.
It's getting, I think it's...
That now you market it properly. So that the government sees,
Yes, I agree. I think, Eric, thank you very much, and Janet. The first time I came to KNH 12 years ago, it used to be called a funeral home. And even the manager was called a funeral home manager, and a mortician,
a
body cleaner. The first thing I did was we agreed that, we have to change even these names. And we actually changed it from a funeral home to a farewell home. And in fact, the staff were even very excited that, you don't call them funeral attendant, but you call them farewell home executive. It inspired, motivated them. And as we speak now, is actually one of our centers of revenues, in the sense that we have actually renovated it. We have got a world-class, parlor. And what has happened is that we also provided, very excellent services. We also have challenges because what happened is that with such a big facility, and we are talking about referrals, people coming with very complicated, conditions. It's unfortunate that we also have some people to go through that facility. It also gives us some challenges when we talk about numbers. It's because also all those abandoned, unknown Kenyans, and particularly when those who have died there, we actually have to hold them. Sometimes, and I want to make it public, that even I think 2 weeks ago, we actually put in the papers, we had about 200 bodies.
And that was, it was a public conversation.
Yeah. So what has happened is that we have separated. We have now another parlor here, and then we have the other one, for those abandoned bodies. So the point here is that that's a great facility. We want actually to improve not even the services, but also probably even to have, other services there. For example, even a chapel.
There's
the chapel which we have there. We want to renovate it. We also want to see whether we can also, provide all other services that someone requires, to take a body home, including even a vehicle, and those kind of things. We can compete equally with anyone else.
Yes.
Yeah. So, but one point, Eric, as we are putting it, we need to brand. We need to rebrand it. We need to market. We need to promote some of our services. In the past, public hospitals are not supposed to market. We are not supposed to be seen as if you are selling. Right. But I think with my orientation, we have to do something, to that effect, so that people know exactly the services we have there.
Yeah. From what I observed, though, there was quite an inflow. Yeah. Okay. And so I just thought to myself, it's picking up. It seems extremely busy. And yet they didn't seem overwhelmed. There was just the dignity for me really stood out. Just the patience, the talking people through, and it just constantly was extremely busy. So that was good. Sorry, Mariam, you're going to say?
No, that's really good to hear. I was still on the morbidity train because how we dispose of unclaimed bodies has come into the public limelight over the last few weeks, what we saw happening in several parts of the country. But mass graves, things like that, it's like, okay, there was a permit given, there wasn't. What is KNH's essential procedure for disposal of unclaimed bodies?
And why are they unclaimed?
Yeah, thank you very much, Marian. One is that, like any other clinical procedure in a hospital, it's actually documented. In fact, we have an SOP for, even how to bring in a body, how to store the same body, and even how to record the same, and even how to the same to be collected, and even individuals who must sign. In fact, even the viewing, has to be done. And the individuals who are collecting the body, including the vehicle that is going to carry that body, we have to take the registration number and even the name of the driver. So we have a very, very elaborate system, of managing of this. Of course, we cannot miss one or two sleeps, it can also happen here and there because of the numbers we have. So we have a very, very elaborate system, in trying to manage this. Similarly, we have abandoned bodies. What happens that sometimes patients are brought to the hospital, or they come actually there through accident, and we cannot trace their relatives, or some of them actually abandoned and left by their relatives. We also have street families, individuals from the street families who are brought there. It also happens that we also have some communities, somebody has died because of a certain disease, it becomes an issue, and they don't want to go and bury. So we actually sometimes left, with hundreds of some of these bodies. And being a government institution, we have to respect that, everybody is an asset of state, and therefore we have to follow the right procedures to try and get their relatives. We actually put in the papers. Recently we did it, and actually we got about 8 bodies identified by their relatives, and we have actually allowed them to come and go and bury them. But the rest, we have no option but actually to take them, to go and bury them respectively, following government procedures.
Those numbers were very high, the ones that released recently.
Yes.
And over 2/3 of them were children.
Yes.
How do you end up with so many children? Is it that, and many of them are newborn? Explain that journey of actually ending up with very many unclaimed children's bodies.
Yeah, one thing is that even though they are called newborns, children are categorized in between 0 and below 5 years. And what happened is that in that case I've mentioned to you, we have had situations whereby, some mothers deliver, I think maybe even preterms, and for example, I think a preterm, and for them, they find it very difficult to go and bury.
Yeah.
And some of those preterms are left behind. For us, probably might not even identify this, for the public might actually conclude that's a newborn baby, but it's actually a preterm. We also have had, of course, certain situations whereby, some of the mothers come, very late stages. I think as I mentioned to you, sometimes because of some of the industrial actions taking place, they come, probably mismanaged, in very, very difficult conditions. Some of those children, probably are born stillborns, and we have them there. And it happens that, some families decide not to actually to take them, maybe to decide they can't take them because they don't even have a name. We have gone through a lot, in fact, trying to convince some of these people that this is your baby, this is your child, take them. So we also have had, street children, girls coming over. They all, in fact, most of the street families, they all deliver at KNH. So because one, we allow them, we access them, we support them. So, and when they go through some of these conditions, they leave some of those children there. One thing that I think we should be applauded is the fact that, we record them, we identify them, and actually we communicate that we have this. And we have to find a way of actually, giving them a dignified burial.
Okay. Just a quick question. Let me change the tangent to the issue of nurses and the brain drain that we were mentioning earlier. So Zacharias says, some years back, specialist nurses and senior nurses weren't going as much. The cost of living, I guess, has gone up, and pay slip deductions have gone high. There is no balance. They're being poached by European teams. So if we pay the nurses and specialists well, they won't be poached by these European teams. That's also partly why I was asking the question of budget, which is we have so much good time. I think healthcare professionals should be the best paid people in the country, alongside teachers. There's some professions that essentially hold a country together. It's a foundation, right? How do we, as we're thinking of how to increase this revenue and even reduce what's coming from exchequer, how do we make sure that we're paying our professionals even better so that we're able to retain this quality talent? You're saying some of these specializations take 2 years, and that's before all the other years of education, and we also deserve to keep this talent in-house.
Yeah, that is a big question. I think that should be a question to be answered by my minister, in charge of health and or probably the PS. But all I can say is that one, if you got the best material, and you're the best, definitely you'll get traction. And I think we should see the positive side of it, that we are producing the best and we are giving the world the best. I know that.
Let me flip it. It's good that we are producing the best.
Yes.
It doesn't serve us anything if we produce the best and 6 months, a year later,
They're
they're
gone.
in a
Abroad.
European country somewhere.
Yes, I agree. I think there is a downside of it. But I think if you are good and smart, you'll get that traction. We can't help it. It's actually a natural, a natural course. And even to some extent, I think it is the same Kenyans who are actually sending us money here. They are the same ones actually who are building and even investing in our country. So sometimes we have to look at it from that perspective. The only thing that I think we need to stem, some of these, I think, brain drain. And it's not only in healthcare, even teachers. You just go across the border to Uganda here, you find Kenyan teachers there. Rwanda, I think they are there, and that kind of a thing. What I can say is that one of the reasons that probably has been taking this out, not necessarily also money alone, is also probably, I think, housing. Sometimes housing is also a challenge. And for us at Kenyatta National Hospital, in fact, we have gone out of our way to ask government to support us, in providing, decent and, modern houses to our staff. And already we have managed to get approval that we are going to get institutional houses, about 1,500 of them, done by the National Affordable Housing Program. And already they're actually on the ground. The other thing is that
where in Nkomo?
yes, at Kenyatta
at Kenyatta itself.
Kenyatta itself. And they are going to do 1,500 houses, modern houses. We also look at the issue of terms and conditions of service, and that's why we are saying that we appreciate our unions. They negotiate. They demand improvement of pay for their members, and that's what has happened. And I think as we speak now, Kenyatta National Hospital are probably some of the highest paid nurses, in the public sector in Kenya. The only thing that we are saying that, there is always room for improvement and probably adding additional benefits. For example, now I think medical cover. These are some of the things that probably, are taking some of our nurses out, and even doctors out of our country. I think the other thing is that we also need to start thinking differently. I think in the healthcare sector, that we can also probably start having what you call home cares. Because some of the nurses even who are going out of the country probably are not even going to work in hospitals.
Yep.
Actually, they are going to work in homes. They are going to work in estates. And I think this is a phenomenon that we need to start in our country. That we can also have these services provided in some of those environments and being managed by our nurses or even being done by our doctors. So there are quite a number of things. The other things that of course we bond them for a period. And it also becomes a challenge because sometimes they wait for that bonding and then after that they take off. So, but the point here is that we need to come with a long-term strategy. We can't, of course, be crying for every day that they have left. I think for me now we are coming up with a strategy, to look in the next 10 years. How many specialized nurses do you require, in different specialties? How many medical specialists and doctors do you require in the next 10 years?
Yep.
So that we can actually have a proper plan that,
ahead.
We will not be saying at the same time that we don't have enough doctors, but we have a number of them actually living in the country and they are not employed.
Yeah.
We are saying that we don't have, we have nurses who are not actually employed, and we are still holding them around. I think a long-term plan. And I think this can actually be done either through our ministry or even through even us as National Referral Hospital, just to sit down as healthcare experts to see how best we can have a long-term plan, for our country.
Last question. Question of paying suppliers from Nicholas Kipto. Ask why they're not paying suppliers the bills of last year, May and June. It's really disheartening and messing up with banks. He says there are no supplies at all, and he knows it. Ata food hakuna. Okay.
Yeah, I think. Thank you very much, Mariam. I think Mariam. Sorry.
Mariam, yes.
Mariam,
yes.
Yeah. Let me start with the food. I think this issue has come up before. And, I would like to say this, that we have never missed food, to provide to our patients at KNH. In fact, one thing that we know, as health workers and even health experts, that the most important food on earth, the most important drug on earth is actually food for a patient. You can have all the medicines that you want to give to a patient, but if there is no food that patient will not make it. So we have never failed to have that food. And I think the allegations which have come before were not even from our patients. It never even came from their caregivers. Well, the caregivers are there. They could have actually raised the issue. It came from other quarters. And even as we speak now, we have all the varieties of food that our patients require. In fact, we even have specialist foods because we have also specialist conditions for our patients, and we provide that. So what I can say is that I think for the suppliers, I mentioned the suppliers of May and June, we have had incidents, where we have had challenges, in some of the verifications of some of the claims. Because as we speak now, we have actually paid most of our suppliers, of course not fully, I can't lie, we have not paid them fully, and because we have got different contractual agreements. Some of them, it takes 30 days to pay, others 60 days agreements, and therefore we pay them depending on that. Sometimes we also probably, and I think like any other organization and even individual, you cannot have everything to pay everything. And what I can say for May, June, I think it's something that I can go and check physically or even personally to know what actually happened.
Yeah.
But I know there are some claims, even there are some people who have claimed that they have not been paid from 2016, and you actually ask them to provide the documentation, to check who received them, where are those records, because in government you cannot pay, unverified claim, it becomes an audit query. But for Kiplagat, I want to ask him actually to see me after this. Keep talk. I think 2 o'clock today, I'll be in my office. Come, I'll handle that issue.
Okay, I think that's where we leave it for now. There's always a lot to explore, like I said earlier, with somebody like you who holds your position. Wishing the nurses all the best and really hoping that other healthcare workers just feel honored as well. And thank you very much, Dr. Richard Lesiyampe, for just spending the last 2 hours with us, walking us through some of the things that you're working on. We are now going to transition to Mwikali hosting a conversation on coping with lupus, the great imitator, lupus lifestyle and what patients can control. That's on Your World on NTV. And then on Nation FM, Brian Eseli and Claudia Naisabwa will take you through Vibe Shift. From me, Janet Bogwa, Eric Latif and Mariam Bishar, thank you for being with us. We'll see you back here soon.